Hello everyone. The topic for today is cough. This is a cardinal manifestation of respiratory disease, although many other etiologies are likely possible. Cough is a protective airway reflex. It functions to dislodge mucus, airway secretions, or mechanical and chemical irritants that might be trapped in the respiratory airway. Cough reflex pathway is deranged in a variety of diseases, and the basic pathologies can either result in aggravation or the suppression of this reflex. If the cuff reflex pathway is exaggerated, it will give rise to respiratory muscle fatigue. It can also accentuate the pain from rib fractures. Importantly, it will increase the intra-abdominal pressure, thus giving rise to low back pain, abdominal and inguinal hernias, and also lead to urinary incontinence. Similarly, continuous cough will hamper your speech, and thus it has various psychosocial implications. In the second condition, where the cuff reflex pathway is impaired, it will give rise to retention of airway secretions and aspirated material, thus giving rise to infection, atelectasis, and respiratory compromise. First, I will discuss the mechanism of the cuff. So, cuff reflex pathway, it is initiated by a sensation of the mechanical and the chemical irritant, which is done by the TRPV channels. These channels, they are located in the laryngopharynx, in the airways, and in the external auditory canal. And the sensation is taken by the ninth and the 10th nerves. Okay, the fibers are A delta and C fiber pathways, and they will reach the nucleus of tractus solitarius that is present in the medulla. Now, after that, the efferent arm of this limb is activated, and this is initiated by first an adduction of vocal cords. So there is a closure of the airway. After that, there is a forceful expiration that is mediated by contraction of these expiratory muscles. This contraction is then just followed by the sudden release of this laryngeal contraction. So the airway velocity is increased, and with that force of expiration, the trapped irritants, they are dislodged. This is the basic mechanism. Now, the cuff reflex pathway, it can be impaired in a variety of diseases. So if I say that the cuff reflex is impaired, you should think of first whether the force of generation of expiration is it adequate or not. So you will measure the expiratory velocity generation in the patient. This velocity generation can either be normal or it can be decreased. If the velocity of generation is normal, in that condition, think of dynamic airway collapse that might occur, or if there are some hard secretions, that is secretions that are difficult to dislodge, like in cystic fibrosis or primary ciliary dyskinesia or dynamic airway collapse that can be seen in tracheomalacia or bronchiectasis. However, if the generation of force itself is decreased, in that condition you should think of respiratory muscle weakness, like in myasthenia gravis or CNS depression due to sedation or anesthesia, or when the patient is not able to obtain the closure of the airways. So impaired glottic closure that can be seen in vocal cord palsy or say tracheostomy will impair the cuff reflex. Also, rib fracture will cause increased pain on inspiration, and thus it will limit inspiration, and thus cuff reflex pathway cannot be initiated. Now, the classification of cuff. Cuff is divided into three basic categories. One is the acute cuff, then we have subacute cuff, and then we have chronic cuff. Acute cuff is less than 3 weeks in duration. Subacute cuff is 3 to 8 weeks in duration, and chronic cuff is something that lasts for more than 8 weeks. Chronic cuff is very important. The evaluation must be extensive. So you have to consider various pulmonary and cardiac diseases in this patient. When I talk about acute cuff, think of infection, think of aspiration, and think of inhalation of various respiratory irritants. If subacute cough is your domain of discussion, that is when the patient gives a history of 3 to 8 weeks of cough, you should think of the residuum of the inflammation that is from a tracheobronchitis episode. This is referred to as post bronchitis cough. It generally lasts for less than 2 months in duration. Now, in the approach to the patient, you will first take a dedicated history and perform a meticulous physical examination. After that, you will go with testing, that is pulmonary function testing, and a baseline investigation like chest x-ray. To elicit the exact cause for the patient, you will go with CT scan, which is the gold standard investigation. Never forget to examine the nasal passages, the posterior pharyngeal wall, the external auditory canal, and also the tympanic membrane to exclude pathologies in these areas. Now, we have a special patient, a patient who presents to you with chronic cough. You ordered the investigation, and the investigation turns out to be normal. So the patient has normal chest x-ray along with chronic cough. So in these patients, think of etiologies that might not be directly related to the pulmonary system. So think of cough variant asthma, think of post nasal drainage, think of GERD, think of eosinophilic bronchitis, ACE inhibitor uses, air pollution, and cough hypersensitivity syndrome. I will give a limited description, a very brief description of these various etiologies and the most important ones in them. So first, cough variant asthma is where typical asthma triggers, okay, they will produce cough, but without any sensation of shortness of breath, that is chest tightness and wheezing in the patient. The treatment remains the same. Go with low dose ICS along with Saba Prorineta, that is as needed. For post-nasal drainage, remember allergic, infectious, and vasomotor etiologies. For the condition of ACE inhibitors, remember ACE inhibitor use, the incidence is around 5 to 30%, and the cause is related to the increase in bradykinin substance P, which is normally degraded by ACE enzyme. So that will stimulate the sensory fibers and that will give rise to pathology. Now, this particular condition is not dose related, and you must put the patient on a 1 month trial of discontinuation before you confirm that this is the diagnosis in the patient. If this diagnosis is confirmed, you can switch the patient safely to ARVs, and that will be the treatment for this condition. Cough hypersensitivity syndrome is a diagnosis of exclusion. It is generally seen in females. The treatment is similar to that of neuropathic pain. Go with gabapentin, pregabalin, and amitriptyline administration. Then we have eosinophilic bronchitis. In eosinophilic bronchitis, the sputum eosinophilia is more than 3%, but there is no expiratory airflow limitation or bronchial hyperresponsiveness that is seen in asthma. There is obviously increased FeNO. So whenever in the expiratory air NO is increased, you should think of asthma. You should think of eosinophilic bronchitis. The treatment remains the same, that is ICS. The air pollution, remember that it can be indoor, outdoor, it can be occupational. Then we have symptomatic treatment. So we have narcotic cough suppressants, like which are the most effective drugs that are available to us. The most common of these are codeine, hydrocodone, and morphine. The adverse effects are important. You should remember that it can have addiction liability. There is constipation and there can be drowsiness that can be induced by these agents. Then we have dextromethorphan and benzonatate, and these are less effective drugs. They act away from the respiratory center. Then we have inhaled lidocaine. The adverse effect is that there is an increased risk of aspiration in this patient. Current research is needed because there are a lot of limitations in the available drugs at the moment. Just remember one drug that is currently under investigation, that is P2X3 channel antagonist, as is gefapixant. This is the chapter. I hope you will read the book, and that concludes this session. Thank you.